Next presenter is Dr. Deeksha KATOCH. She's an additional professor at PGI, basically doing a lot of work on ROP, pediatric retina. She's close to 105 index publications and a lot of awards she's won. So a lot of ROP work is being done here. She's doing a lot of surgeries for ROP and of course involved in genetic research as well. So now I'll like to invite Dr. Deeksha for a presentation.
Thank you, Jaspreet sir, for the kind introduction, and thank you, Professor Maria, for such a wonderful insight into genetics of eye diseases. My topic is to concentrate on the, cases with retinal abnormalities, and as far as causes of severe visual impairment and blindness in children in our population specifically are concerned, so the two most common causes that have come up are whole globe abnormalities followed by diseases of the retina and the vitreous. And as far as the etiology is concerned, hereditary diseases are top the list in terms of etiological classification of the causes of severe visual impairment and blindness from blind school studies from south of India. They have been replicated from Maharashtra, and there's also a study from AIIMS New Delhi. So when we look at hereditary causes of retinal diseases, that is the inherited retinal diseases, it actually encompasses a wide spectrum of disorders which can have systemic associations. So there can be syndromic IRDs or non-syndromic or isolated to the eye. There are different inheritance patterns that could be autosomal recessive, autosomal dominant, or X-linked. These diseases are also characterized by sometimes incomplete penetrance and variable expression, and these could be progressive or stationary. They could be generalized or predominantly macular or involving the optic nerve. They could, as far as the photoreceptors are concerned, they could be predominantly rod cone, cone predominant, or cone rod dystrophies. There could also be vitreoretinopathies. So as ma'am has also said, that this is a genetically heterogeneous group of disorders with a wide variability and a lot of phenotypic overlap. So the disease that is retinitis pigmentosa, which we commonly diagnose as of today, has more than 100 gene associations. So really, if in today's era, if you want to make a diagnosis of retinitis pigmentosa, we need to do a genetic testing so that we can do a genotype-phenotype correlation for these diseases. Of all the diseases, of all the genes that have been mapped to retinal, inherited retinal disorders, at least 328 have been identified as of March 2025. And you can see that the slope that this is expanding. So this area is growing. So I'll just show, one, and if time permits, another case where the use of genetic testing helped me in identifying or making a definitive diagnosis for a case. So this case I just saw a few months back. This was a 10-year-old male child who presented with complaints of predominantly floaters and decrease in vision in the left eye of 1 week duration. There was no other significant history. The past history was important, that he had been diagnosed as an exudative retinal detachment at 1 year of age, and since then he had poor vision in the right eye. So this was the right eye, no light perception, cornea showing a band-shaped keratopathy, and you can see that yellow glow because of total exudative retinal detachment with massive subretinal exudation. The slides are moving on their own. Is there a timer setting to it? So the left eye, the visual acuity was 6/12. Anterior segment was unremarkable. The posterior segment, we see this wide field fundus photograph, which is showing predominantly a vitreous hemorrhage. And temporally, we can see that there are occluded vessels. So what was this case that we were dealing with? There was no exudation. So we did a fluorescein angiogram. The fluorescein angiogram is showing blocked fluorescence because of the hemorrhage. We can see areas of capillary dropout. So that's about it. And we can see areas of neovascular leakage. So we made a clinical differential of 1 FEVR, coats, but bilateral, yes, rare, but can present. Was it an acquired condition? Was it a vasculitis? Was it IRWAN? For vasculitis and IRWAN, the only odd point was the other eye, which had an exudative detachment at birth. So FEVR and Coats was top on the list. Still, we were keeping a possibility of FEVR, but the parent screening was negative. So how do we go about from this case? We also noticed that there was an abnormal lock of gray hair on this 10-year-old child. Was this important? So routine investigations revealed that the platelets were low, hemoglobin was also low normal, TLC was also normal but on the lower side, there was deranged LFTs, and a workup for vasculitis was negative. We did a laser indirect ophthalmoscopy as guided by the fluorescein angiogram. So what should have been done? Can we stop here? No, we cannot stop here because we haven't yet arrived to the definitive diagnosis. So a genetic testing was ordered, and we found these compound heterozygous mutations in the one in the exon and one in the intronic segment of STN1 gene, which was consistent with an autosomal recessive inherited cerebroretinal microangiopathy with calcification and cysts, and this was also confirmed on parental segregation in both the parents. So we tried to fit into the phenotype. So yes, because there was no other family history, it was autosomal recessive. There was sign of that gray hair which fit into premature aging. There were some signs of a low count, pancytopenia. There were some liver abnormalities and vascular and retinal telangiectasias, though the telangiectasias was not prominent, but on the nasal we looked back, and on the nasal aspect of the fluorescein there were very isolated few telangiectatic conditions. To fit into the picture, we ordered an NCC head, and it did show the calcifications, multiple of them in the subcortical white matter, right frontal, parietal and left occipital region, and a bone marrow was also advised after consulting a pediatric hematologist, and it confirmed the presence of a markedly hypocellular bone marrow with a cellularity of 5 to 10% and reduction of the normal hemopoietic elements. So the diagnosis of a Coats plus syndrome, which is actually a telomeropathy, the gene complex is part of a 3-gene complex, that is the CST complex, that is responsible for shortening of the telomere lengths. Until date, only about 4 patients have been reported. The problem is that there is a high risk of mortality because these children have risks of GI bleeds, and that can result in mortality. So how did this genetic testing? It helped us in a lot of ways. It helped us in establishing a definitive diagnosis. It allowed targeted investigations. It helped in guiding for appropriate follow-ups with the appropriate multidisciplinary team. At the back of the mind, we have a prognosis for this child, and can we help at this time? It helped in parental counseling. We have counseled this child to the parents to undergo and consider a bone marrow transplant. The child is under follow-up in hematology unit for any signs of worsening counts and drop in hemoglobin and the LFTs. So case 2, this was a young adult but with history of low vision and difficulty since childhood, who was referred as a case of choroiditis to the uveitis clinic. His examination was 618, 636, and he was myopic. And why it was labeled as choroiditis? Because of these pigmented scars that were seen in both eyes in the superotemporal quadrant. So, and an OCT showing the presence of cystoid macular edema or foveoschisis. The autofluorescence also showed hypoautofluorescence in the areas of the pigmentation, but what was notable was this ring of hyperautofluorescence that you usually don't see in a uveitis case. This is more consistent with the presence of a retinal dystrophy. And the fluorescein angiogram also did show some leakage, and possibly that can lead on to confusion. But if you look carefully at the angiogram, we see that the leak is not really from the vessels, it is at a deeper level. So we did a full field ERG, and this is what the full field ERG, the left panel shows what we expect to be normal. So there was markedly diminished dim flash ERG, also the dark adapted, and we saw there was reduced flicker responses. It was consistent with an electronegative ERG. A genetic testing revealed NR2E3 homozygous mutations, and which was segregated in parents as well. And this was a variant which was consistent with the enhanced S-cone syndrome. So again, how did genetic testing help? It again helped in establishing a diagnosis. It avoided unnecessary treatments and investigations and helped in guiding follow-ups. So why genetic testing is important in retinal diseases? I think it has been very nicely highlighted by Professor Maria as well. Whenever we have a strong suspicion of an inherited retinal disease, and for that we need to do a complete ophthalmic examination, including history, ancillary testing, It helps us to classify and establish a diagnosis. It helps in prognosticating. It helps in generating awareness, because in our population, mostly the parents or the family members don't even know that possibly they may be dealing with a patient of a genetic disorder. And definitely it helps in genetic counseling and educating the family members for subsequent pregnancies, and even for finding candidates for suitable gene therapy, as ma'am has also shown the results of Luxturna. The RP65 mutations, we have more than 20 mutations that are linked to LCA. And our population may not be having those kind of mutations. So we need to look at our own population cohort. So to conclude, gene-based diagnosis of IRDs is rapidly expanding. It is providing new insights in the diagnosis, and gene therapy, as has been shown, appears to be promising in some cases. Thank you.
Thank you, Dr. Deeksha, for those interesting cases. Any questions or comments? Yes. Dr. Arif? Dr. Arif, after that, you can ask.
Once again, great cases. This is really a great session. That first case, that gene, I've never seen that before. That's really interesting. So that's it. Yes. But I just want to make a quick comment. I'm a big advocate for genetic testing, obviously. But that second case that you showed, that ERG was pathognomonic for enhanced Cohen syndrome. So if the genetic testing came back without an NR2E3 or NRL mutation, I would tell them go do it again because you didn't find it. So sometimes we have phenotypes that we know it has to be this. And if the lab doesn't give us the answer that we're expecting, then we tell they're wrong. Yes. So this is why it's so important to be clinically, accurate and aware of these things.
Excellent cases, Dr. KATOCH. Just one question, 2 of your cases had VUSs. They segregated, but is that enough to establish and say confirmatively that this is the diagnosis and counsel the patient?
Yeah, because when we looked at the literature, all the other cases had also a STN1 mutation. So possibly the intronic variation that was there, that was a novel one for us. And you saw that there are only 4 reported cases till date. Right. So possibly that VUS is possibly a novel mutation. So that's what we are writing up this case as well. So just not all VUS, possibly VUS, we really need to go deep down into our population cohort, because we may be dealing with a lot of novel genes and mutations that are linked to IRD phenotypes in our population.
Yes, but then even if it's a VUS, like you go ahead with the counseling as if it is pathogenic.
Definitely, because other investigations are all fitting into the diagnosis, so that is why.
Thank you.
Thank you. We can move on to the. You have a comment? Yeah, we can take one comment.
Sorry, just on the VUS. So because she did the MRI and it showed the calcification, then you can upgrade it based on the phenotype. If you're just not sure, you still have to tell them, we cannot 100% confirm this, but we think this is the cause, because the labs will only issue a report if they're 100% certain.